We'll call the December Board of Health meeting to order. For the record, there's a copy of the Open Meetings Act on the north wall of the legislative chambers if anybody wants that. I do have official notice of public record in front of me. And with that, we'll have roll call.
Wade. Festerson.
Here.
McNally.
Here.
Rogers.
Here.
Weiss.
Here.
Jones. Wilkin.
Here.
King.
Here.
Espinoza.
Item 2 is approval of the minutes of the November meeting. Is there a motion?
So moved.
There's a motion. Is there a second?
Oh, hang on. Who was a motion?
McNally.
Motion Festerson. Okay. And who was second?
I don't know yet.
Okay.
I'll do it.
Festerson.
Chairman, I need to make that correction.
Okay, please.
And that's to please add my name being in attendance on the minutes of.
Okay.
Thanks.
Noted. With that,
Move to approve with change.
and I'm assuming the second's the same.
With change.
Roll call.
Okay. Wilkin.
Yes.
Rogers.
Yes.
King. Okay. Jones. Weiss.
Yes.
McNally.
Yes.
Espinoza. And Festerson.
Yes.
Okay.
Item 3 is approval of the action items. We have 6 items. Seeing nothing to my awareness that needs to be needs to be removed, is there a motion to approve items A through F?
So moved.
Motion by Weiss, is there a second?
Second.
Second by Wilkin. Roll call.
Festerson.
Yes.
McNally.
Yes.
Rogers.
Yes.
Wilkin.
Yes.
King. Espinoza. Weiss.
Item 4 is presentations. Item A is pediatric community CHNA data review from Children's. Who's up?
And here we go. And let's share real quick here. Thank you. You're welcome. And beginning go. There we go.
Just advance the hair.
Yeah, just use the.
Okay. Good morning. Thank you for having me present our community health needs assessment, the pediatric side, to you today. My name is Megan Connolly, and I am the Vice President of Community Health and Advocacy at Children's Nebraska. Most of you are aware of what the Community Health Needs Assessment is. We are here to present the pediatric data which was obtained from parents who have kids 18 and under. And so we have completed this assessment. This is a triannual assessment that is done, and we have done this with our colleagues from Boys Town National Research Hospital and Douglas County Health Department, so thank you very much. We also have very important partners in our effort, which you can see from our graphic up here. One note that we are very happy is this year we added 2 more partners who participated, and that was the Creighton Institute for Population Health and the Sarpy-Cass County Health Department. When we look at who we define as community, for years we have included Douglas County, Pottawatomie County, and Sarpy County. This year we were able to add Cass County, and so we had about 85 people from Cass who responded, so we were happy to include them this year. So a little bit about the data that you will see is that we obtained this by doing a phone survey. And how we got the the children, I'm a nurse, so if I say patients, I'm sorry. It's really children and parents. But the parents of these kids were pulled from a random sample from Children's and Boys Town, and then we de-identified their personal health information and we did a phone sample. We also did random dialing, so we made sure that we had a fair distribution throughout those 4 counties to make that we weren't just getting the patients that were in the hospitals or within the systems. We also do a stakeholder survey. Many of you may have actually received this survey. We sent out about 500 surveys to a very specific list of people that we know have a vested interest in child health. We had about a 40% response rate, which was really good for this because we do need leaders in our community to tell us what their concerns are also. This year we added something that we're very proud of, and those were the listening sessions. We partnered with the Creighton Institute for Population Health, and we actually sought out groups from underrepresented population to make sure they had a voice in telling us what they needed. Those were parents who are refugees or immigrants, foster parents or youth who have aged out of foster care, and parents of LGBTQ+ kids. That data is not being presented today, and you don't have that in the packet that we gave you in your handout because that is being done in a report that we'll have early this next year, which is only a couple of weeks from now. So when we look at what the perceptions of our community health needs for the pediatric population, on the left you will see what our parents told us. So their biggest concern for children under 12 was obesity, nutrition, and exercise. Once you hit the 12 years and up, that adolescent, you can see overwhelmingly it was mental health and other, which made up a variety of topics. On the right, you will see what that stakeholder group, those who are vested in child health, and the 9s and 10s, so the highly rated, 71% said mental health. So we have a very clear direction of what we need to work on. So a little bit about the data. We want to provide today for you a very high level view of this. In your packets, you will see it's a more detailed summary. But we've also included a QR code, and that QR code will actually take you to the CHNA, or the Community Health Needs Assessment, so you can actually dig down as far as you want to go from what I'm about to tell you today. So the highlights that we want to include are from these 4 areas. So I'm going to start with mental health. I don't think probably anyone in this room is surprised at these results. Depression and anxiety diagnoses have only increased every single cycle since 2015. You can see the graph on the bottom. The red is anxiety, and the blue-green is depression. The largest disparities are in Northeast Omaha, low income, in girls, and Black children. Sadly, throughout my whole presentation, I'm going to be telling you that's the disparities in most all of the findings that we had. What makes this one even harder is the little area on the right. We did ask if people were aware of how they could get help, and that number went down. So the diagnosis level went up, numbers went up, and the awareness of how they can get help went down. When we're looking at health conditions and mortality, when we think about health conditions that we see in pediatrics, asthma is so huge, and it affects so many systems of those kids' bodies, and so we really pay attention to that. That number has continued to increase since we started this. We started it in 2012. Every year it's gone up. It's gone up from a high of 9.5 to a high of 14%. And again, Black children and children living in Northeast Omaha are the greatest affected. In fact, 1 in 4 of our Black children that answered this survey have been diagnosed with asthma. We have a graph or a fact up here about diabetes. To be honest, pediatric diabetes is a little different than you see from the adult population and the adult community health needs assessment. We will continue to watch that. Different reasons, community, what's happening out in the environment doesn't affect the diabetes like it does in adults. But I know the fact on the right is something Douglas County is watching very closely, and that is infant mortality. And you can see our rate per 1,000 live births is 11.7 deaths in our Black children. This has gone up, and none of ours really meets what the Healthy People 2030 target is, which is less than 5 per 1,000 live births. So we have work to do, and I know Dr. Hughes is laser focused on this too with her groups. Social determinants. The next area that we want to make sure we're paying attention to are those environmental factors and what can we do with that. For social determinants, again, we found that 30% of families do not have cash on hand if they had a $400 expense that they needed to take care of. Since 2021, this has doubled. This is of great concern because we know that the environmental things that our families are living with definitely impact child health. And so if you look over to the right, 1 in 4 children in Northeast Omaha live in unhealthy or unsafe housing conditions. This is compared to 1 in 10 if you look at that the greater metro area. So 1 in 4 in Northeast Omaha, 1 in 10 in our metro area. And then over 50% of families are food insecure in the same area, and adding Southeast Omaha, this is compared to 30% of the metro area. And lastly, access to care. As a pediatric nurse for 30 years, this one really gets me. So Dr. Hughes, I know this will get you also, but the newborn vaccine hesitancy has nearly doubled just in our 3 years. This is not all of the vaccine things that happen with COVID. This is the newborn vaccines, the ones that we traditionally get when those babies are born up through their 2nd year of life. You can see that this rate of hesitancy has doubled to 14.8%. This survey was done prior to what's even happening now and all the talk now, so it would be interesting if we resurveyed to see what that is looking like now. 13% of the family survey had used the emergency department more than once in the past year. Northeast Omaha and low-income children have the highest emergency department utilization rates. Children with, the good news though, children have been able to get dental visits and they've been able to get dental care. That number has increased, and also the eye exam and vision care. So if there's a positive in what we've seen, we did see that both of those numbers did improve. So when we look at our data, we need to determine what areas that we need to focus on, and also Boys Town National Research Hospital is doing the same. So how Children's Nebraska did it is we went through a prioritization process. We want the voice of the community. We appreciate their time for participating in the survey, and we committed to them we would take this data back to them. So this year we went on what we called a gallery walk. We did 5 of them out in our community in person, and then we did one virtually, and we posted it on different social media avenues so people could easily see it. We were really happy because we had 154 in-person visits and over 300 people did the virtual data gallery walk. They gave us feedback, and so what we asked them were very pointed questions about what children's needs to focus on. And we asked them what their thoughts were on the access to care, pediatric mental wellness, and social drivers of health. They gave us feedback, and then we asked them more specific feedback. Of those, what do you want us to focus on? So for example, for access to care, we said, okay, you agree we need to work on that, what do we need to do? And so they told us that we needed to make it easier to get access to care out in the community. And then we asked them, okay, who should we focus on? We know what our data says, but tell us what you think. And so for that one, for example, they really want us to focus on our refugees and immigrants and our Black population. So we did that with each of those areas, and we took their feedback, and we're now going to take away and do our implementation strategy plan and determine what we need to do for the next 2 years. Boys Town went through the exact same process. They gathered stakeholder input internally and externally. They also went out and got community member feedback, and then they're putting their plan together. Their identified priority areas are very similar, just slightly different. They're going to also focus on pediatric mental health. They're going to look across all areas of the continuum. They're looking at access, education, and family support, pediatric nutrition, activity, and physical activity and weight management. And then they're going to also look at hearing and speech concerns. They are very well versed in those areas, and they're going to focus their talents on that. Again, you have a packet with the more detailed summary, and then if you want the actual data, which is how many pages, Chrissy? 195 pages. This QR code will take you to the actual report. Any questions?
Good morning.
Good morning.
How are you?
Good. Thank you
Good.
for having us.
Good. You mentioned the sampling. Did you oversample in any of the counties?
I have the numbers of the responses we've got.
Okay.
Did
good.
you hear that? Oversampled in Northeast and Southeast Omaha.
Perfect. And sorry, I had questions written on the pages, so I'm trying to get to them. You mentioned living with someone with serious mental health issues. How did you define serious mental health?
You want to come
Yep,
up?
I'll come up.
Chrissy Tonkinson was vital in our process. She is our data and evaluation person at Children's.
Yeah, I like her.
That question is parent defined. They're asked, has your child ever lived with someone with a serious mental health issue? And it's up to the parent whether they answer yes or no to that.
Okay. Sorry, one more question.
No problem.
You mentioned that there was improvements in the dental visits and dental care in the past year, which is great to hear. How do you foresee that Children's contributed to this improvement?
That's a good question. You know, Children's partners with UNMC, College of Dentistry, and also Creighton, but really it is our FQHC partners and people out in the community making the difference with that.
Okay, that's great. The Child Health Data Gallery Walk, I had a chance to see one of those, so that was great to see. What were the 5 locations?
We did one at Children's, the Barbara White's Community Engagement Center, 75 North, the Highlander space.
I write those down.
Yeah, you have those? They're in my head somewhere.
I don't think I wrote those down.
The Yates Building, and there was one more.
Anything in South Omaha?
We had trouble getting scheduled there. We are working right now to translate the gallery walk to Spanish, and we'll be bringing it to South Omaha in the first quarter.
Okay, that's what I wanted to know.
Yeah.
All right, I think that's all the questions I have for now. Thank you.
Thank you.
Thank you.
Anybody else?
I have a question.
Go ahead.
Good morning. Thank you
Good
for
morning.
all the great information. Question in regards to vaccine hesitation. It does break it down to location of the county. Do you have the breakdown per ethnicity? Are we,
I'm able to look at that on my back end, and I can definitely send that to the group.
thank
Yeah.
you. I would appreciate that.
Of course.
Regarding vaccine hesitancy, especially in newborns, what is your organization planning on doing? Ideas? How could we partner with you to change that hesitancy?
Thank you for that. I have been, I meet with Dr. Hughes quarterly to talk about things, and vaccines are huge. We participate in a program called Max the Vax, and of course, this last time that we did it, it looked a little different because it was focused more on COVID. Now we're going to shift that. We're going to participate or continue to participate in that program, but really focus on standard vaccines. Children's is lucky, and Boys Town has the same resources that we have strong pediatricians who really go into education. And we just have to educate. And then what we want to do is take the ability to get to vaccines to people instead of having them come in and get them. So we're working on that. Children's is looking at ways to actually go out in the community more. And I'll always keep Dr. Hughes informed. And she knows of our initial dreams and how we're going to make that happen. But that is something that's on our radar. It was just in the Nebraska Examiner yesterday. If you saw that article, that not only is the hesitancy, but the rates are now going down in Nebraska. And we've always done really well. We'll get back up there.
Refresh my memory, it's been a long time. What's the number of vaccines for newborns between 0 and 1 year? Don't they get something like
They get
a lot? Like
They get a lot of components,
okay.
but they're able to mix the components into one vaccine. So really, like the DPT is one vaccine,
Right.
but it's actually 3 vaccines if you look at it
Right.
because it's the 3 mix. I'd have to count. To count. We do measure, it's called Combo 10, and all the way through age 2. So we measure that monthly to see how we're doing with all of our patients, and we are seeing that number go down. Yes.
Thank you.
I'm just curious, because of the specialty of this community health needs assessment, do you all show this to MOAC or the superintendents?
We have not explicitly shown it before. The superintendents are on our stakeholder survey, and I will be sending out a link to that list to the report. I would love to get to present in person. If you're able to help connect us, or somebody is able to help connect us, I'd love to present in person.
Yep.
Awesome. Thank you, Dr. Hughes.
The vaccine is the hottest thing right now.
Yeah.
But what's the I'm trying to think, what's the first one to come back if it comes back? Measles?
Ooh.
That seems to be the one that's as I'm hearing.
Well, as Dr. Hughes would tell you, pertussis has made its way back. Measles would be this is a Megan statement and not an official statement, okay? But measles will be devastating. Kids get really sick. People get really sick with measles. And it spreads. If I had it, you would be at risk. It's not like the 6 feet rule. It's just air. And so I don't know which one would be the first. There would be several that would be extremely concerning.
Mm-hmm. Okay. Okay. Jeannie was, I was asking her, we're a mandated school vaccine state, but we're not other than that. You see any threat of that?
I don't know if I can answer that.
Okay.
Do I see the threat? I see a lot of threats. I don't know what will happen. I know we have smart people. And if we continue to educate and just get the facts out there and avoid all the jazz that's happening besides the facts, I think we've got really smart people in our state.
Okay. All right. Anybody else? Thank you. I might, once we get a chance to dig into this, it'll be interesting.
Yeah.
Okay.
Great. Thank you. Thank you for having us.
Appreciate it. We'll go to item 2, STD clinic update.
All right, good morning, board.
Good morning.
I was just telling Marty that you guys are probably gonna get sick of seeing me lately. So, this morning we're gonna give an update on our STI control program as well as our STI clinic. So up here I have Molly Elston, who is our clinic supervisor, and then I am proud to announce we have Hannah Campa is our new STI control supervisor. So, she's been with us for about a month now. All right, so we are fully staffed. We were when I did this, and then we were able to promote one of our PHNs to a clinic coordinator position. But I just want to give a shout out to all the staffing within the clinic and control programs. They have done a ton of good work and have really picked up the slack when we have been down staff. So I truly appreciate them and just want to kind of recognize them at this point. Our STI control program, like I mentioned, Hannah started as the supervisor, and then Enrique Lopez also started as a prevention specialist. He is coming from Nebraska AIDS Project, has been doing outreach work for several years there. We've known him for a long time, so excited to bring him on with us. All right.
Okay, so again, I'm Molly. I'm the supervisor for clinic. I'll give you a little update about what's been going on in clinic, what we've been doing, some of our successes in the last year, some challenges we've been having, and then some goals for the future. So our clinic is an immunization and an STI clinic, so I'll present first about STIs. So a little bit about what we've accomplished in 2024. We started in partnership with the community health workers in our health promotion section on a social determinants of health screener. So we screen all of our full visit STI clients for different social determinants of health. And if they need support, we connect them to a community health worker. Also in March, we started doing DOTComm. So DOTComm is a strategy to prevent STIs. So it's doxycycline taken ideally within 24 hours after unprotected sex to prevent infection. So that strategy is something that at the time was CDC had not yet formally added it to its recommendations. So it was an innovative practice that we took on after discussions with Specialty Care Center and some other partners. And so we really emerged as a leader in that strategy. We've had a lot of other health departments reach out to us about using that strategy. We've educated several clinics in town as well about that strategy. our electronic health record, you might have heard in previous Board of Health presentations about that, or in our notes on our section. So in November of last year, we were still charting on paper in our clinic, and then we were adding electronic information into a software. So as of mid-November last year, we began with our electronic health record. So now we're doing all of our patient documentation records in our electronic health record. So a couple of things have happened this last year. We've integrated with Nessus, which means whatever we chart in our electronic health record goes straight into Nessus, which is our immunization information system. That happened in June. And then just recently, last month, we integrated with labs. So all of our labs now are pushed straight through the state lab for orders, which has been really nice for staff and just for data integrity as well. We also established a partnership with Access Period, so we're able in our clinic to provide free period products to any clients who might need them. They're also in the vending machines. We had our site visit. It's about every 4 years that we get a site visit from DHHS for our clinic licensure, and we didn't have any findings. That went well. We hired a clerk to fill our open second shift position that does our evening and weekends using our new Sherwood funding. And then as Leah had talked about, we have the new clinic coordinator. The goal for that clinic coordinator is to really increase our ability to conduct QI projects, to look towards more sustainability by establishing billing in clinic for those that have insurance and are able to have us bill private insurance and Medicaid, those sorts of insurances, as well to work on expanding our usage of the EHR and taking advantage of all of those tools, and then improving or supporting staff technical knowledge, and then updating policies and procedures, those sorts of things. Some goals for our STI clinic for the coming year. We are reorienting our clinic to answer to what our clients are asking of us. Some of our clients really like to have schedule appointments so that they know that that's available. They don't have to wait and not know how long they're going to wait. Some clients do really need a walk-in setup, so we'll be establishing a walk-in Wednesday, probably in January. Leah alluded to this a little bit, but we'd like to onboard, or we have a position now posted for an open public health nurse to fill that vacant role that our clinic coordinator was previously in. And then we will hopefully be able to secure funding to add a part-time public health nurse to support the evening crew. We also hope to soon be able to do multi-site swab testing. So rectal, pharyngeal, and then vaginal swabs in our express setting so that a client doesn't necessarily have to see a provider. They can just pop in, get a swab, and get results later. We hope to, as we expand testing, as we expand clinic staff, to increase the number of clinic visits. I'll go into specific goals on that. And then we hope to continue to deepen our use of the different EHR capabilities. So things like online check-in, text reminders for our patients, and then possibly patient portal. Those are all things that we can take advantage of and that we'll start testing. We also are exploring doing rapid start prep in our clinic, which would be a huge innovation for us, something that we've been wanting to do. So we're exploring that, and hopefully sometime spring we might be able to start doing that. And then I talked about that billing and sustainability piece. And then 2024 has been a challenge for staff. In terms of funding and staffing, we've had a lot of staff covering other positions that were vacant. So staff have been working really hard to keep clinic moving forward and to keep serving our clients. Quick trends in terms of what we're seeing in terms of visit numbers. So in 2023, we saw about 317 clients a month. And then in 2024, and this data is only through December 12th when I pulled it, we've seen about 318 a month as we increase with that extra part-time staff and with the filling of that vacant public health nurse position and just some increased efficiencies. We're hoping to get to 400 a month for 2025 and then 450 a month for 2026. Some quick updates and accomplishments and challenges for immunization clinic. So we've had a lot of different challenges and funding changes for immunizations due to some federal funding limits. There's been an increase in demand for vaccines for adult program, which provides
free vaccines for uninsured folks, but the funding has stayed the same, and so there's not adequate funding to provide vaccines to all uninsured folks. In terms of that program, it actually used to also cover underinsured folks, but now we can only vaccinate uninsured people. For COVID-19 vaccines, the allocation that DHHS gets from the federal government has been depleted, and so we're not able to get more COVID-19 vaccines for our adults. So we've got about 50 doses left for the rest of the season, so that's a challenge. As well, Mpox vaccines are not available for ordering anymore for uninsured individuals. We've got about 4 doses left. Once those are gone, we'll have to help navigate patients to try to support them to find an option where they pay out of pocket, unfortunately. So those are some of the challenges in terms of funding changes. We have funding through the end of 2024 for COVID. I'll show you what we were able to do this year in terms of outreach for fall vaccines. In 2025, we'll have our funding through the county for immunizations as well as our VFC funds, but we won't have COVID vaccine funding anymore. So that'll be a challenge in terms of making sure we can still serve folks as well as we can with the resources we have. This highlights the COVID-19 and flu pop-up events that we've done the last 2 falls. So this fall and last fall, we've increased the number of vaccines we gave at these pop-up clinics in communities. These are by request by community partners or by reaching out to community partners to see if they'd like a clinic. We partnered with Methodist College of Nursing to increase our impact. So they also bring flu vaccines and they're able to give it to anyone who comes. We can give flu vaccines to anyone who's VFA eligible or VFC, which is vaccines for children eligible. So this year we did already more vaccines than we did last fall, and we did almost double the number of clinics we did last fall. Let's see. In terms of general immunization trends, so looking at routine vaccinations and COVID and flu broken out, this data is from January 1st to December 12th of both years when we look at annual doses. So you can see for annual routine doses for both children and adults, VFC and VFA, we increased the number of doses we gave. For fall COVID-19 doses, we increased the number of doses we gave for both children and adults. For fall flu for children, we decreased a little bit for fall flu doses for adults. So overall trend, we've administered more vaccines this year than we did last year, both at our pop-up clinics and in our clinic. This one? Okay. So that's kind of an overview of our clinic items. I can do an overview of that social determinants of health referral program that I referred to earlier. So we did from April 15th to December 4th when the data was pulled through that referral program and clinic. Is this all clinic? Okay. So out of the clients that did that screener, we had 207 that were referred for community health worker follow-up. You can see breakdown of gender identity and race and ethnicity here, 92 females, 107 males, 1 non-binary individual, race ethnicity 67 white, 65 black, 30 Hispanic, and then 45 other. So a good mix of different gender identities and race and ethnicity. You can see some of the different services we referred to and that the community health workers supported navigation on. And just a reminder, this is a totally new program. So all of this is an addition to what we were doing before, which is great that we were able to provide this added navigation. So referrals to food pantry, housing services, utilities. There were healthcare referrals, so for mental health, for medical care, some access to care support, so helping with application, let's say, for a Medicaid insurance, or that's the benefits one. So 69 benefits support, so Medicaid, SNAP, and WIC support in terms of getting signed up for those programs. And then through this specific referral program, we gave out 2 Narcan doses. We also have sort of an informal route in clinic that I don't have numbers on, and I know we've given a great number of Narcan out in clinic to clients when a CHW was not available. So that's been a huge plus, and clinic's very excited to be able to offer that to clients who walk in and might need Narcan for themselves or for their family or friends or whoever. syphilis update. Wanna?
Okay, so a quick syphilis update. As you can see, our website has been updated still through the dashboard. This is the most recent information. We've had 25 infectious cases and 64 latent. Some of the things that we've done so far this year, there was a press conference, as you all know, I think that was June 26th. We also did the Wash University CEU program. Molly did a great job with coordinating some penicillin supply plans with our emergency response team. Our STI DIS ended up doing some provider notification and education. So they went to, I believe, 36 clinics and educated providers on syphilis treatment and what that kind of reporting process looks like. Do you want to talk about the DOTComm?
Yeah, we also, as a part of that provider notification that we shared with those clinics and the education we shared, we talked about DOTComm as well as did some deep dives with a couple of clinics who were interested in that methodology. We went on site and walked them through what our process and procedures looked like.
And then lastly, we were able to purchase some combination HIV syphilis point of care tests that they have been using in outreach settings so that we can actually capture folks where they're at and provide that testing there and then get them in for additional testing if needed. So, all right. So with our STI surveillance, as you can see, trends for chlamydia are looking roughly the same. We had a slight decrease, but I don't ever take that too direct just because I like to look at the trends over a few years. As you can see, gonorrhea has gone down a little bit, which I am glad about. And then syphilis, we have seen a slight increase, but it's not quite at our highest from 2021 yet. Now for syphilis investigations, our disease investigators have been working hard. There were over 1,300 investigations that they conducted, and they discovered that over 1,000 of them were not cases. And 305 of those were cases, so you can kind of see the breakdown. The reason for the increase in investigations is due to a change in kind of our triage when we get positive labs into the surveillance office. Prior, they were doing, just without getting too deep into syphilis, but looking at labs that had a certain increase rather than just any positive lab that came through. And with the increase in syphilis that was happening, they actually started to follow up on all positive cases of syphilis. So that is why the increase in investigations. But as we're seeing, we're still have high numbers of cases, but it is not looking quite as drastic, we're hoping. Now for interview status, this is where we really truly find out if there are partners that we need to follow up with and also really encourage individuals to get treatment. 77% of our syphilis cases were interviewed in 2024, and this is up through December 12th. And 14% were lost to follow-up or unable to locate, 5% other, and then 4% refused. So this is the big one that I like to look at because I think treatment status is the most important when we start to look at this. And with our infectious syphilis cases, 99% of them were treated, which that is huge in my mind because that way we're actually able to get folks treated and they're not spreading to other individuals. Our latent syphilis is sometimes harder to convince individuals to follow the longer treatment program, which is 3 shots of bacillin over 3 weeks. So it is sometimes harder to get those folks in for their 2nd and 3rd doses of that. But we have a 92% treatment rate with our latent syphilis as well. Some of the other things we've been doing is a media campaign. We have collaborated with Sarpy-Cass, 3 Rivers, and Lincoln Lancaster on this. This is through Commando, has done this for us, and they will have several different ads going out over dating sites, etc. I think there's Facebook, Grindr, Scruff, but there was also, I think, Tinder. They're doing some on Tinder. So there's all kinds that they're doing. This was through some funding with UNMC, and with that, they wanted us to really hone in on chlamydia education. So that is sort of where this came from, and really to talk about the DOTComm was another big thing, and this is where Molly was able to have the conversations with some of our partner health departments about the importance of DOTComm. Our STI outreach program, there were 243 outreach events in 2024 so far. Some of those included Black Family Health and Wellness, a doula passage program, Cinco de Mayo, National HIV Testing Day. They have reached over 3,400 individuals. They had 199 individuals tested in outreach settings with a 6% positivity rate. They distributed almost 180,000 condoms and then had 77 at-home testing requests, and then ultimately got nine of those tests returned with a 22% positivity rate, which I think shows that it is a need within our community, and we just got to figure out how to encourage folks to actually mail those tests back when they have them. So a quick vending machine update. This was as of I can't remember the date, last week sometime. We are currently actually over 500, I believe, at this point. But you can see this is what the reporting for me on the dashboard end looks like. And Sienna Francis has had the highest number, but Douglas County was not far behind. Our health department, the one right outside, has been very close. Washington Library and Nebraska Urban Indian, and then American Dream. So we're excited that individuals are actually utilizing our vending machines.
Hold up, Leah. Let me ask you.
Oh.
Go back to
Yeah.
that. So you said this since what's the time period on this? Because like
This was
I don't-
December 16th, and this is only 3 weeks from when we started. So we.
well, no, that's what I wanted to ask you. Because I don't know if members of the board can see it because they may not have it computer-wise. Because it says 1/2020 through 12/16/24.
Yeah, that's just when they had it in there. I mean, I can change that. It's not going to change because
Okay.
we didn't have any data as of November 20th.
So basically, this is somewhere since the last board meeting till now.
Yes, this is since they've been installed.
Okay.
This is what we've seen.
Are you going to add this to the report that you put in
Yes.
to the board?
Yes.
Okay.
Yeah.
Okay.
And then also on this piece, I forgot to mention, you can also see the time of day that individuals are using this. Majority is in that afternoon time frame, but you can see it's really in the evening as well. So 6 at midnight. So it's great. I'm glad to see that individuals are using it. Some breakdowns. As I mentioned, December 16th, there were 434, but I can also break down who's utilizing it. So we had about 64% non-Hispanic, 65% in that 18 to 44-year-old range, 49% female, and 49% white. I do have the other breakdowns. It's in my notes below. I just did the majority on this slide, but I can give you the breakdowns as soon as I exit out of the slide set.
Do you know what's in the wound kit? I'm curious.
Oh, there is a whole slew of things, but I want to say Band-Aids, alcohol wipes, gauze. We ended up getting like 7 different things that go in this kit just to help clean up any wounds. That we had like little washcloth tabs that you can add water to when it expands so you can clean, a little bar of soap, I want to say. So there's hand sanitizer, all kinds of stuff that you would need to properly clean a wound.
Could you go back to that slide and just read what that, it's hard to read from back here, sorry.
It's top line is condoms, lube. Second is wound kit. At the top one is 85. Wound kit is 82. Early detection pregnancy test 53. Plan B 47. STI kit 43. COVID-19 antigen 40. Fentanyl test strips 33. Drug dispensal pouch 19. Tampons 18. Pads 14.
On the test kits, how many of those are returned? Are we tracking that, or?
Yes, we are. So I actually was talking to our outreach team yesterday, and there were, as of yesterday, there were actually 48 test kits that have been distributed. We've gotten 2 returned. So it's a matter of, I've talked with the vending machine company to maybe add in that we might request an email on that just so that we can follow up and say, hey, did you have questions? but I still am trying not to collect any identifying information on these because I want folks to feel comfortable coming to them.
Is it prepaid postage for the?
There is a drop box, so it's kind of hard to
nice.
tell, but on the side of the machine, there's actually a little area where you can just drop the test kit in, and then the courier gets notified and he picks it up and brings it to the health department for us to process.
I like that. It may be helpful to also think about prepaid because then that way they don't have to go back to that location to drop it into there. So then they could just put it in a mailbox and.
And I know we have that available because of our at-home testing program. So I'll see. The problem, honestly, was trying to get the right size box. Like we had to cram everything in this tiny box. We really wanted to put 3 testings, so for urine, rectum, and pharyngeal swabs into one box, but it wasn't big enough and it wouldn't dispense. So I will try to see if we can add that in. I think that's a great idea.
Yeah, just to have multiple ways.
Yes.
What's the turnaround? Oh, I'm sorry. What's the turnaround time from the point where they give you the swabs till when they find out?
Once it gets back to the department, so that should happen within the next day. Let's say someone drops it off, our courier goes to pick it up and then drops it off at the health department. We get it inputted. I would say it 3 to 5 days. I mean, 5 days is the max. However, usually MPHL is really good about getting those processed as quick as they can.
So walk-ins as well, if they come to the clinic and swab testing is done there.
Same length of time.
Mm-hmm.
Where are our STI clinics located?
Our STI clinic is at the Midtown campus.
Okay. Yeah, so there's just one. And
Just one,
Okay.
yeah. We'd love to have lots of funding in the future to have outpost sites, but not. That's
Are
our
there-
outreach team.
And then
helps
outreach
with
team
that.
has additional locations, so they will just set up a table at health fairs, at the libraries, community centers, and offer urine screenings at those locations.
And then when we talk about our community health needs assessments, I think it's accurate to say that what we're seeing again this go around is a number of challenging areas that we need to address in terms of public health. But when compared to national numbers, most cases it's not as severe. But that is not the case with STIs, I believe. We're still very challenged compared to national numbers. Do you agree with that assessment?
Yeah, with like syphilis, we're still below the national average with our syphilis cases. However, I think we've had high numbers of chlamydia, gonorrhea in Douglas County compared to national levels. However, one thing that I have noticed is after talking with colleagues in other areas, we also do way more testing than other cities, counties within the US. I mean, I've talked to partners and they've said, like, how do you provide all the free testing that you have? We are very fortunate and I'm thankful for that. But the more testing you do, the more you're going to find. So I think that has some relationship, but we still have a high number and still trying to combat that. So.
Okay, so about the testing, like, do you guys report based on the specimen source site at all? So, like, is it rectal versus oral? I have just been surprised with the number of positive oral or other sites rather than vaginal, that like the vaginal will be negative and the oral will be positive. So just considering maybe doing more reporting on that so that.
Yeah, I know in the past, we've had to look through, like, especially clinic, and now that we have the EHR, it's going to be a lot easier. I was, like, hand calculating that back in the day of, like, okay, here was our positive rectal, here was our positive throat. How many of those would we have seen had we not done extragenital testing? So, yes, I will happily start reporting and pulling that information.
And clinic really emphasizes to our clients the importance of testing for sites where you're having sex. So not just, some people think they can just drop a urine and that covers everything. So we make sure to emphasize to clients, no, we really need to test the sites where you're having sex so that we know where the infection is and can treat it appropriately.
Okay. And then for the vending machines, like how are people being contacted if they're positive, if we're not providing any demographic information? Like
So when you return the test sample, so when you return your urine specimen to either the box or over to the health department, there is a form within that we collect patient information. So that's where, because it is a lab specimen, we have to have certain things for lab reporting. We have to have name, date of birth, address, phone number. And so once we get that, then we follow up with the individual to give their testing results.
And it looked like even in clinic, you were handing out X number, but only half were being returned. So what's the like outreach or follow-up process with that?
So with our at-home testing program, our prevention specialist has been reaching out. So initially, folks will submit something online to say, hey, I'm interested in having an at-home test. She will follow up with them and call them and say, hey, what types of sex are you having? You might benefit from receiving this test as well. Can I send that? So she will follow up, find out, make sure she has the right test kit tailored for that individual, and then follow up with them in about a week to find out, like, hey, I mailed you a kit, any questions about it? And then at that point, I mean, looking at resources, we don't have a huge team. If I had all the staff in the world, I'd say we'd have someone following up on a more regular basis after this. But if they don't submit it back, I mean, that's truly on the individual. We don't want to force them to test, but.
I have just a question about the Rapid Start prep. You mentioned that you're going to start doing that, but kind of trying to figure out what to do. Have you looked around town to see if there are other clinics who are doing it that you could potentially reach out to?
Yeah, I this summer went to an HO conference and had a lot of good conversations with other public health departments who are doing this, who can't dispense, but who are able to get samples of that medication. And so Leah made contact with one of those and we're exploring with them. Our clinic staff have never done that, so our nurse practitioners would need training to make sure they're comfortable with it. So that's where we're going, is get the training, make sure that we've got the right resources in place. And Leah's been doing a lot of work on that.
We've been working with the state level too, the HIV counseling and testing program at DHHS actually has a few individual health departments that they're working with to do a PrEP pilot. So they've actually added us into that. I'm hoping that will cover some of the initial labs, because that's always been my concern, of paying for those initial labs that come through. So working on that, we've got the initial conversations happening. They are considering us one of their PrEP pilot sites. So
how soon do you think that could start in 2025?
I'm hoping. I have probably a more greedy timeline of like February, March, but you know,
Yeah.
it takes time sometimes to get processes set up.
Thank you.
Our staff are really excited about being able to offer that. It's
Yeah.
something that's been on our wish list for a while.
Mhm.
So what it would look like is someone would come in, we'd identify them as at risk for an HIV infection, and then we talk to them about their interest in PrEP. And then we'd hopefully be able to just send them home with 7 days of PrEP so that they could get started while they're waiting to get an appointment for long term.
Thank you.
Let me ask you, I didn't see it, but this is what I'm interested, and I might not answer now. So from when the Board of Health in 2022 declared it an epidemic, and I don't know, some of you all may not, I don't think anybody was here then when it happened. They declared it an epidemic, and then they were keeping stats. And then the curious thing that I saw is like the age of a lot of high STDs was 16 to 20, somewhere around in there. And then that track followed, and the next highest became the age of like 20 to 26. I'm just interested in that data point to see if that group that started at 16 to 24, then it went to, it's like the high number was following that particular age group. And I'm just curious if that trend is going.
So it's not in the 35 to 40 range now.
Okay.
I think that's where you're going with it. But
I'm understanding when that trend stops.
yes,
At some
so
point you get
I
to the
want to
point.
say, and I will have to follow up for sure. I don't have the numbers on hand today, but I have them back in my office. Gonorrhea and chlamydia have separate age groups that they peak in. So I am happy to get that information to you
I know
all.
you ain't got enough, but I'm curious to see what that number
Yeah.
is and what's the new hot age.
Yeah.
Okay. All right. Even thank you. Appreciate it. We'll go now to item 5, any health director's report.
Good morning.
Good morning.
All right, just a few updates for you today. Strategic planning has been going very well for the department, and we actually today, after this Board of Health meeting, will be having a consensus retreat, if you will. So basically coming together, looking at all the feedback we got from partners, from leaders, from the people who work in our department to see really where our strategy needs to lie for the next 3 years. And I do say 3 years because as we've kind of explored our strategic planning and looking at all of the different assessments that are out there, like the CHA, Public Health or PH-WINS, just a number of different assessments that are out there that are also on a 3-year cycle that we would really like to align our strategic plan with. We actually have the opportunity to do that right now, so we're going to do that. It also allows us a little bit more agility when something new is coming up, or if we need to make changes. A 3-year cycle just makes it a little bit easier to be nimble and change as we need to. So we're going to do that. So consensus retreat today, we will be kind of hashing out that feedback and determining what our priorities ought to be. And then in January, early January, the action planning for that will occur. So we are going very well through the process. We've had great participation from our staff. So I'm very, very interested to see what comes out a little bit later today. Also, the adult community health needs assessment is complete. I think I may have told you that last month. Right now, the data has not been released publicly yet. However, that is coming also very soon. Hopefully, we are going to have some community listening sessions in the next month or two, depending on how we can get facilitation set up for that with the wellbeing partners. I am happy to bring that data to you and report to you, the board, in a couple of different ways, depending on your preferences. I could present that data as it is right now, which is kind of a summary, if you will, or I can wait a few months and come in with kind of the deep dive. So essentially, I've asked my data team to do a deep dive into the raw data that we have on the adult CHA, and actually they will be doing a deep dive as well into the pediatric. But I'm very interested because, you know, we look at the summary data and we see where there are likely disparities, but we don't really have enough information in that bar graph to tell us really what those disparities look like. And so I'm very interested to really tease out what the magnitude of some of those disparities look like, if we are able to do a better job of figuring out who and where needs the most assistance. And so I will be able to share that data with you. But of course, since we literally just got the data in the last month, that is not ready for prime time yet. But I am happy to do either of those or both as the board sees fit or would like.
Dr. Goose?
Yes.
If you do the deep dive later, would you also have the community listening session data at that time to kind of have some of the mixed methods in terms of sharing it out?
Right. So the goal is, as we have the summary data now, and what's coming in the next few months will be those listening sessions or community conversations, if you will, where we can get some more information from the people who live here, really, and use our services to tell us what their priorities are. Very similar to the process you saw presented by Children's today.
So you'd be able to present on both of those a few months from now?
Yes.
Okay. That's my preference. I don't know about the other board members, but.
Yeah, Dr. Hughes, I would say I would even say do the summary now, because I'd be curious to do the summary as soon as you can, and then
Okay.
I'd be curious to see what the difference is once you do the deep dive.
You got it. We can do that. All right. We just celebrated our 75th anniversary. So Douglas County Health Department is 75. Thanks to those who were able to join us for our celebration. It was a really lovely time to just be together and celebrate, and also to celebrate some of our partners in the community who have had a really, really great impact on not just our organization, but on the public's health over the years. So that went wonderful. We are currently prepping with NALID, Nebraska Association of Local Health Directors, for the upcoming legislative session. They are actually in Kearney today talking about priorities and figuring out what that's going to look like. I am obviously not in Kearney today. However, I have had quite a few conversations with the president and the executive director prior to, so I am familiar with the conversations, and they know my stance on really the different priorities that they'll be discussing. I would suspect that probably the biggest priority that will come out that NALID will focus on will probably be around funding, making sure that we're protecting any public health funding that is in statute, and ensuring that those things aren't going away. I wanted to give you a quick update on rats. I know I brought this to you last month, that we have a neighborhood in town that is experiencing a bit of a rat problem. We suspect that the rat problem has been worsened by the presence of a facility near the neighborhood that has had a lot of debris around outside on their property, where rats may be finding food sources, also nesting, because it's that time of year. They're looking for places to nest. And also, there's a sewer line that goes kind of through this neighborhood, and due to the flooding that occurred several months ago, some of that forced some of the rat population up to the surface. So kind of just a bad situation there. Councilman Ron Hugg convened a town hall on Monday night for members of that community to basically come and have some questions answered and hear more about what's happening to eradicate the rat issue. I was very honored to be invited to the town hall, and our environmental health chief, Eric Bradley, and our environmental health specialist too, in our sanitation program, John Ruff. Probably a lot of you know John because he's been here for a bit. We're able to be there. John did most of the presenting on what's happening because he's really the one heading the health department side of this response. It is a collaborative effort, so it's health department, it's city, it's the company that's there with the debris, it's pest control companies that have been brought in to develop plans to eradicate this issue. Some interesting conversations were had at that town hall. It sounds like it's possible we could actually have maybe a bigger perimeter than we thought we did. So we heard neighbors reporting seeing rats where they haven't in the 50 years that they've lived there, kind of outside what we thought that original perimeter was. So we, of course, are using that information to make sure that we are responding appropriately. And we are currently working to set up an online reporting form for rats. We do not want to have to go out for every single time somebody finds a rat. So we are helping them, educating them on how to appropriately dispose of rats if they find them, if they're dead, and then to actually report if they're seeing rats and how many. This form actually is going to link directly into GIS, and so we will be able to watch in real time as those reports roll in, kind of where that rat population is as the community is seeing them. So that will hopefully help us do a little better job of casting a wide enough net to hopefully contain this problem. This is just something that takes time, and it takes collaboration from everyone, including the people who live in those neighborhoods, to make sure that they're not leaving food sources available, that they are making sure that any even very small holes, you know, in their property that rats could get into their homes, all of those things are closed. And so we continue to work with that neighborhood. Previously, we'd gone out with letters and gone door to door in this neighborhood so that they had information from us. So we continue to work with them. It's been a great, positive collaboration. It was really nice to get to interact with the neighbors, hear their concerns, and hopefully just build an even stronger relationship to help us get rid of the rats. So that, I wanted to make sure we gave you an update on that. And thank you to Justin Frederick and to Eric and John for working together to start setting up that form, that online form for reporting rats. And with that, I don't believe I have any other updates, but I would happily take any questions you have.
Yeah, I just can't tell you the questions I've gotten at home about this rat thing, and it's not even in the area. But yeah, it's just curious. But I want to add on to your legislative piece.
Yes.
So, because I was supposed to be in Kearney too, but what I am hearing, and I'm wondering if it's good with, on the same concern with you, the funding piece, is, and this is where the relevance is to the board, so the board should know. It was mentioned, so the legislative session, they came in to do the property tax piece. They couldn't get enough done with that. What ended up being the fallback to try to get some victory is a cap on cities and counties. And the cap is to a concentrated area because the cap is not applied to public safety. And then when you get into the counties, it's not applied to the public defender and the county attorney's office. So that means the health department is under the lid. And so that lid is 0%. Now the fight, hopefully, is to try to get the lid increased to 3%. The city's budget runs a little different because I think the county's budget, assessments probably need to run about 4 or 5% to break you even, to have salary increases and everything like that. So if it's 3, there's still a hit down. But that to be said, is that my understanding is they may go after the healthcare cash fund for property tax relief. And if that happens, that's a little bit of a hit here. But the point of knowledge for that is I think Lancaster and Douglas are the only ones that give any other money outside of the healthcare cash fund to their health department. So if the healthcare cash fund for some reason disappears, you basically have every public health department in the state of Nebraska that leaves, except Douglas and Lancaster maybe, unless SARPI chooses to start giving, which they can, they just haven't.
Right.
And so,
yeah, and we have provided information on how we utilize our state funds back to the director of DHHS Public Health, because I know that she's been having conversations within DHHS. You know, there's, I think, a pretty strong commitment to ensuring that people understand how those funds get used and what the impact would be if those funds went away. So we are having those conversations, you know, trying to quantify the impact and what that looks like. And of course, we will just work how we need to work to protect that funding if possible.
I just wanted to thank you for your help with the rat situation and working with city partners on that and city council members. And then also thank you for the involvement in the city's climate action and resiliency plan. You may have seen that was approved yesterday by the city council.
It was the first thing I looked up this morning when I woke up.
Yeah, so we're excited about that.
We are too.
But it's only as good as its implementation going forward, right? Yeah. So we look forward to working with the department and the many partners that were involved in that. And of course, you know, direct impacts to health equity and environmental health that we think will come out of that plan and be very positive for all we're trying to accomplish here too.
Thank you. I appreciate that. And I have to say that just the beginning conversations that we've had with the city around that climate action plan and, you know, what potential partnerships could look like have been so positive and just very collaborative. And I really, really appreciate the opportunity to, move forward in this particular space because we know it is something that is going to become more and more important as we move on. So we're looking forward to it as well.
Thanks.
All right.
Okay.
Thank you.
All righty. Any board members have questions on any of the reports that were submitted? Okay. With that, I do need 5 minutes of, got a question? I do need 5 minutes of everybody's time for an executive session on personnel. And so what I'd ask is for a motion to go into executive session to discuss personnel, but also just say to the public, we will take no action when we get back. So we'll just end the Zoom and go from there, and we'll reconvene and adjourn after that's over. So is there a motion to go into executive session for personnel? So moved. Motion by Washington, second. Second by Wilkin. Roll call.
Sorry. Okay. Festerson?
Yes.
Weiss?
Yes.
Espinoza? McNally?
Yes.
Jones? King? Rogers?
Yes.
Wilkin?